Hello, we are at New Jersey Heart and Vascular Care Cardiology Office of Dr. Kintur Sanghavi in Princeton, New Jersey. Dr. Sanghavi, thank you so much for inviting me to your office to make this MedTalk segment interesting and educational to our audience. Looking forward to learn from you on how you provide comprehensive cardiovascular care to your patients in the office. Thank you so much for your time. We are at New Jersey Heart and Vascular Care office in Princeton, Dr. Sanghavi's office.
Welcome, Dr. Patel. Welcome to the NJ Heart and Vascular Care office here in Princeton.
Thank you so much.
Here is our waiting area and the intake, our reception area where our team is here.
Hello.
We are having a patient examination in the procedure room. So we can start with our patient exam procedure room where we can do examination as well as investigation.
Yes. So Dr. Sanghavi, my question is, a lot of people are putting their regular checkup, including cardiac checkup, off due to pandemic. What is the message for those patients now?
So I think, there was a right reason to not go out. There was a good reason to not go for preventive care because, we knew it was the human interaction. This was the first virus in our history which was only present in human beings, and it was only contaminated from human to human. So it was a very good idea to avoid contact while the pandemic was going on. But as things have improved, as we are all vaccinated, as the pandemic is under control, I think it is a good idea now that we remember that only disease is not coronavirus. People don't just, till today, people die more likely from a heart disease than a coronavirus infection. So it's very important that we do not forget our overall health, and our overall health and preventive care has a tremendous impact. The whole healthcare system is focused on that, and I think it's now the time to get back to those preventive care.
Yes. So when the patient comes to your office, what can they expect? What do you do in the office setup here?
So in the office, first of all is always the clinical evaluation. We talk to the patient, we get their vital signs, we examine them, and that's how we can identify some of the difficulties or abnormalities the patient may have. We can also, understand what are the investigation they need. And from that evaluation starts investigation. So the whole healthcare industry is moving towards minimally invasive treatment or office-based treatment, because we all know that hospitalization and prolonged hospitalization is associated with mortality and morbidity. So, all the surgeries are becoming minimally invasive, and similarly, a lot of testing is moving into the outpatient base. That's where we can identify, diagnose the problem, monitor the problem. One of those, so there are multiple testing we can do in the cardiovascular office. One of the things we do here in the office is the echo machine. So this machine can this is M8. This can do echocardiography of the heart. We can do carotid Doppler. We can do transcranial Doppler to see the flow in the brain. We can do the ultrasound of the abdominal aorta to see if there is aneurysm or not. There are 5 different probes that we can use with this machine, and we can use that to check the circulation of the leg artery. So if there is a leg artery blockage, if there is a blockage below the knee leg artery, so we can get a lot of ultrasound or Doppler examination study from that. The echo in particular help understand if there is any valve abnormality, if there is a leaky valve, if there is a narrowed valve, if there is a poor pumping of the heart, if the heart pumping is normal, if the heart relaxation is normal or not. So a lot of these factors that we can identify. Based on that, we can either modify the medications to prevent it from progressing, or we can use medications to help alleviate symptoms. And then there are places where the treatment choice is further invasive treatment. So sometimes we, based on what we see here, we decide if the patient needs to go for a catheterization in a hospital, or if needs to go for a procedure in the hospital, or needs a surgery for valve replacement, things like that.
So when the patient comes to your office first time for evaluation, can they get this if there is a reason for them to get the echocardiogram at the same time, or do they need to make another appointment?
So generally speaking, unfortunately, the majority of the insurances require prior authorization, because the concern of overutilization, because the concern of inappropriate utilization, they had to come up with a check and balance.
Yes.
Unfortunately, that check and balance has gone on to another extreme, where sometimes it takes us 2 weeks to just get an authorization for an echocardiography testing. This is ultrasound testing. So there are places when a patient comes in. For example, we had a patient yesterday who had chest pain right in the office. Those are the kind of situation we don't wait for the insurance. We just put this probe on, and I can check if the heart pumping is affected. We know right away that this is truly a heart pain, and we can act on that much emergently. But most of the time, these testings are required. The one testing which I'll show you, the EKG machine, which does not require prior authorization, which we as cardiologists consider as like a fifth vital sign, because the electrocardiogram gives a lot of information about whether the chamber is enlarged, whether the electrical conduction is happening in the right direction, whether a patient suffered a heart attack, or whether the patient has abnormal likelihood of having abnormal blood flow to the heart muscle. So and we can move this EKG machine in every room we go to. But here is the GE EKG machine that we can have digital EKG transfer right into the electronic medical record, and it can give us a lot of information. So this EKG does not require prior authorization, and we use this tool for almost every patient walking into the cardiology office, because as I said, it gives so much important information that the next level in care is kind of guided by this tool, along with the blood pressure and the heart rate and patient's symptoms.
So if someone come and has abnormal EKG, what do you do? Can you do anything in the office, or you usually tell the patient to be transferred to a hospital?
No, so depending on the EKG abnormality, let's say for example, if a patient is having EKG abnormality that's suggestive of having maybe lack of blood supply to the heart muscle, but the patient is not having any pain. So the symptoms and the clinical presentation really makes the major judgment whether we need to send somebody to the hospital or not. But say for example, if somebody has an abnormal EKG and the patient had some chest pain in the past on exertion, or effort angina, or chest pain on exertion, then we can say, okay, let's investigate this with a stress test, for example. So we can do a stress test in the office. That is a non-invasive way of evaluation for presence of blockage. So we have the facility here for the stress test, and we can do the nuclear stress test also. What nuclear stress tests are is basically when we are doing the stress test at the same time, we can take the nuclear imaging of the heart. So basically the nuclear markers are, maybe we can see the stress test machine first, and this is basically essentially a treadmill. And what we do is when patient come here for the stress test, we are checking a resting EKG. So we see the EKG at the rest, we measure the blood pressure at rest, heart rate. Now we have the patient come onto the treadmill and exercise. So basically we are trying to reproduce the symptoms the patient has on exertion. So what happens is, as the treadmill goes into different stage, every 3 minutes or every 2 minutes, depending on the protocol we select, the speed increases, the height increases, and what we are monitoring for if the patient's blood pressure is going up. Normally with exercise, patient's blood pressure should go up. If it is going up, that's an appropriate hemodynamic response. Similarly, we monitor the EKG throughout. So if there is any changes in the EKG, there are changes that we can detect to suggest that there may be a blockage in the heart artery even before patients start complaining of chest pain. And this also gives us their exercise tolerance. So a lot of time the stress test has a lot of prognostic value and help patient navigate their effort in improving the cardiovascular health. So this is a very helpful tool. But now we can add with this are the nuclear imaging, and we have capacity to do that. So we do the nuclear stress test right here in the office. The nuclear stress test is essentially basically we inject a nuclear marker in the vein at the rest, take pictures of the heart, wherever the potassium goes. So in every heart cell that is having a blood supply, or if the heart cell is alive, that potassium is going to enter. Similarly, the nuclear marker will enter the heart muscle. We can take the image at the rest. Then we bring this patient to the stress test, do the stress at the peak of the stress when they are doing exercise or the blood pressure is high. At that point, we inject another set of nuclear marker. Now we take picture of that, and then we compare the rest and the stress image, and that's how we know if there is an area of the heart muscle that get normal blood supply during the rest and abnormal during the stress. That's how we know the patient has a blockage, and at that point we recommend the patient that you need a catheterization and maybe unblocking of a blocked artery.
So one curious question is, if patient is unable to do the stress test because of the physical condition, what are the options?
Very good question, such a good question. So a lot of time patients cannot walk on treadmill, elderly patients. So there are something called pharmacologic stress tests. So we can use medication to give the stress to the heart and mimic the similar effect as if they were going onto the treadmill. So we do the rest image and then we do the stress image after the pharmacologic stress to the heart. So there are a few different medications and we use those medications and we have the availability of those medications.
At the office you can?
Right here, we can do that in the office. We can do the entire stress test in the office, and that really, access is the most important thing right now in the healthcare, that a patient needs something that needs to be done quickly, and I think that's where having this available in the office makes a big difference.
So what I gather mostly that most of the diagnostic studies are done in the office. So that's very good news.
Yes,
Compared to what?
In fact, we have, there are two other areas, right? Like we were talking about what are the heart disease. And we talked about that the heart disease related to heart artery, that's the testing here. Heart related to structural problem, that's the testing with the echocardiogram. And then there is the heart problem related to electrical activity. So we have testing for that also.
Okay.
So we have, we can do Holter monitoring where we can give a monitor to the patient, they wear it at home, and that can give us up to 14 days of electrical activity recording. So these are the event monitor or Holter monitor. So the patient can wear this. If the patient had, let's say for example, felt lightheaded or felt palpitation or felt dizzy, they can press this event button. At that point particularly, it registers the symptoms as well as the electrical rhythm of the heart. And that's how we come back and review this recording for up to 14 days. And we know why the patient had palpitation or why the patient gets shortness of breath on exertion or why the patient passes out or syncopies. And then that we can take to the next level. So the next level is this. This is something we call CMT or a continuous telemetry monitoring. Okay, so this is the ambulatory continuous telemetry monitoring. This can be done for up to 30 days. This is a live telemetry monitoring. What that means is when patients have syncope or patients we are concerned of having AFib or atrial fibrillation or ventricular tachycardia, somebody who had sudden cardiac death kind of a situation, resuscitated, or had syncope and we are concerned if something like that can happen, we put this monitor on, and this is live monitor 24/7 by central monitoring system. So if there is an event was supposed to happen, they will call 911 for the patient in the patient area. They will call the patient. They will notify me about any irregular rhythm. So this is a very important tool. The CMS is really promoting this tool for people who had a stroke, for example, because they want to make sure they don't have atrial fibrillation. So if you had a stroke, this is important. If you had a minor stroke or TIA, this is important. This can detect an irregular rhythm of the heart, which if it is detected and appropriately managed, can prevent happening another stroke. So this monitor helps that way. And further in the vascular space itself, like for the cardiovascular, taking care of the leg artery circulation. So people have pain when they walk, claudication, or if they have like an ulcer in the leg, or they're having pain in the leg even at rest, and sometimes having swelling. So the lower extremity arterial and venous disease studies. So with the ultrasound machine that I showed you, we can do venous studies where we can see if there's a blood clot or not. We can also see something called venous insufficiency, why they have varicose vein, why their veins are enlarged. And if they have something called venous insufficiency, if the valves of the vein are not working well, we can detect that with a specific study, which are really very, very involved study. We have them patients stand up, we have the patient lie down, we have them do deep inhalation and hold breath. So all this we are trying to mimic a situation to see if there is venous disease, there is a delay in the flow back to the heart. And similarly, we have this here, the ABI PVR machine. So this is the ankle brachial index and the pulse volume ratio machine. So what this does is, we use cuff in the arm and multiple level at the leg, and we check the blood pressure at different level along with the waveform, which is what tells us if the patient has a blockage in the circulation at the which level, whether it is at the between belly button and hip joint, is it between hip joint and knee joint, or if it is below the knee joint. And depending on what we find, we can plan the treatment. We can also take it to the next level because some patients have only pain when they walk. So when you check their blood circulation in the leg at the rest, it's normal. It comes with this Doppler, so we can test the circulation. But when you do it at rest, it's normal. Then we put them on a treadmill. And within 2 minutes, 3 minutes, they start having this pain. We recheck the circulation, we see the difference. And this is a very pathognomonic or diagnostic, like a solid diagnostic tool for the leg artery blockage. So that's another thing that we can do in the office, yeah.
So all these non-invasive diagnostic studies, do you see any problem getting the approval from the insurance companies, or these are mostly approved?
We definitely see troubles. A lot of time in my office, Natalie, Jui, they are spending a lot of time on the phone call with the insurance company, unfortunately. Fortunately, they are going more digital. So the insurance companies are now having pathway to have a digital application for the approval. So instead of being on the phone for hours, we can send out the appropriate material and their reviewers can check it and then, give us authorization. But yes, it is definitely not easy. Unfortunately, that's the part of the healthcare system, but we deal with it,
Very good. Thank you so much for your time in providing the comprehensive understanding what is happening in your office. And we wish you all the best in your practice and have a wonderful rest of the summer.
Thank you so much. Thank you so much for the opportunity to talk to you guys or talk to your audience. Thank you for coming out to my office. Really welcome you all. Thank you.
Thank you.